Musculoskeletal injuries in swimming are rare. Due to its nature of consisting of open change movements and are submersed into water, there is no loading or wakeboarding apart from the turnaround. This means that bony injuries are almost unheard of. And so we will be concentrating on soft tissue pathologies and dermatological problems associated with swimming. In swimming, most injuries associated with the shoulder, 55%, lower back, 11%, or knee, 10%. As a basic overview, propulsion during swimming comes from the upper body, and so most overuse injuries associated with the back, shoulder or neck. There is, however, a few lower limb conditions that are related to swimming. The nature of swimming, the foot is placed into a fully plantar flex position to allow for kicking during a swimming stroke. Remembering Wolff's law, which states that a soft tissue injury will adapt to accommodate its regular function. This extended period of time in a maximally plantar flex position causes a shortening of the posterior leg muscles as they are continuously contracting to maintain this desired foot posture. An ankle equinus is defined as a reduction in the ability of the foot to dorsiflex past a certain point. The numerical value of this is debated in the literature and ranges from 10 to 22 degrees past neutral. And so an ankle equinus itself is not a pathology as such, but instead a reduction in the ankle range of motion. Having said this, there is a strong association between an ankle equinus and other musculoskeletal pathologies such as plantar heel pain, Achilles tendonitis and forefoot pathologies, which have all been linked to the presence of an ankle equinus. Treatment of an acquired ankle equinus is relatively simple, as stretching, dry needling and massage are all easily and effective treatments that can be easily adopted into a training regime. A simple calf stretch, held for 30 seconds 3 times a day, has been shown to reduce the severity of an ankle equinus by as much as 80% in 2 weeks.
From Reservoir Swimming Pool. Daniel sustained a medial collateral knee injury, also known as breaststroke knee. Now, medial collateral ligament attaches at the proximal end of the femoral condyle right under to the adductor tibial tubercle. So we've got this ligament right through here, which is painful on palpation.
Oh!
Now to test this structure, to see if it is damaged, we'll get Daniel to lie on his side for us. Yeah. Now just like breaststroke where there's a valgus force coming at the knee, we'll apply a valgus force also to stretch the medial collateral ligament and cause pain. And we're back again looking at the anatomy and the problems associated in swimming at the knee joint. Just as we discussed breaststroke knee, we can also have patellofemoral joint pain syndrome at the knee also. And as in runners also, it can be due to a large Q angle or weak VMO or inactive VMO, causing lateral tracking of the patella also. And we're back reporting live. Management of these conditions is by strength training and symptomatic relief by the use of NSAIDs and paracetamol. The strength training is used to strengthen the vastus medialis obliquus, while also strengthening the medial collateral ligament and supporting ligaments around the knee joint. In order to provide symptomatic relief for outside the pool, foot orthoses may be used to manage the patellofemoral joint pain syndrome, and a knee brace can also be used to help reduce painful motions outside of the pool also.
Hello everyone. So repetitive motion of plantar flexed foot, which pointing away of the body, causing more tension on the muscle to stabilize the foot during kicking in the swimming pool. That's cause more tension on the muscle of the foot to stabilize the foot in the natural position and holding the toes away from the body. Kicking motion causing the foot on the water to excessive plantar flexion of the foot and dorsiflex, while all the muscles like calf muscles, peroneus longus, and tibialis anterior and posterior telling to hold the foot on that position, causing more tension at this muscle, which might cause tendonitis of the tendonitis in the tendons. As you're seeing here in this patient, there is Achilles tendonitis. As you see, there is some erythematic and there is pain in palpation. So, for this cause, we will ask the patient to rest, ice it before and after doing swimming, and we will ask him to do some stretches.
Alright, so swimmer seal occurs due to force from the swimmer at the push-off phase to start a new lap. Injuries that can happen during the push-off depends on how much strength the swimmer is using to push off, as well as incorrect rotation of the body when pushing off. Injuries that can occur include cuts, bruising of the heels, some even can sprain their ankles. The main solution for overcoming these injuries is just practice of awareness on how close and how far away the swimmers are from the wall. This will depend on how much force is needed for the swimmer to push off. Treatment is just the Ricer principle for soft tissue injuries that are caused by the push-off phase.
Swimming pools alongside communal showers and baths are often reservoirs of microorganisms due to the warm, moist nature of these spaces. Some of these organisms are the cause of numerous skin infections and hypersensitivities. Two common conditions are plantar warts and fungal skin infections. Plantar warts are verrucae which are found on the plantar surface of the feet, usually around prominent areas which experience high pressures. The verrucae are caused by the human papillomavirus, which enters through breaks in the skin. The HPV virus is found of warm, humid conditions such as swimming pools and shower change rooms, which can result in plantar warts developing in swimmers. There are many treatments for verrucae, some of which include acid, lasers, cryotherapy, curettage, and numerous folk remedies such as occlusions with banana skins. Another common dermatological pathology in swimmers is tinea pedis and onychomycosis. The causative pathogens of tinea pedis and onychomycosis included dermatophytes, candida, and non-dermatophytic molds. Trichophyte and rubrum is the most common dermatophyte involved in onychomycosis and tinea pedis. It is spread through contact with infected skin cells or contact with fungi in damp areas such as communal showers and swimming pools. Tinea pedis causes scaling, flaking, itching of the infected skin, blisters and cracked skin may also occur, leading to exposed raw tissue, pain, swelling and inflammation. It is most often manifested interdigitally due to the moist, warm conditions which can exist from poor drying technique and enclosed in inappropriate socks and footwear. From these spaces, the infection can spread to the surrounding skin and nails, causing onychomycosis. Once the fungus infects the nails, it can cause the nail plate to become corksic, discoloured and friable. Fungal skin and nail infections can prove quite stubborn and resistant to treatment, and chronic infections can occur. Treatment of these infections can vary depending on the severity and location of the infection, as well as the health of the individual. Tropic treatments such as Lamisil creams and tea tree oil are often used for tinea pedis, while tinctures such as dicterion and vinegar can be used for onychomycosis. Oral agents such as Lamisil can be prescribed to treat the infections if there are no contraindicated medical complications.